Imagine needing a significantly higher dose of uh, dangerous anesthesia just to survive a totally routine surgery.
Right. And all because of a habit you might have engaged in that very morning.
Yeah, exactly. Or imagine a single chemical binding to your blood, like 200 times stronger than oxygen does.
Just actively starving the tissues that are literally trying to heal your body.
It's wild to think about.
Yeah.
Well, you're joining us for another deep dive today, and we're tearing into a question that kind of completely flips how we think about a very common habit. So, can smoking reduce treatment success?
It's a question that really forces you to look at medicine differently, I think, because, the public health message we've all grown up with is entirely focused on the long game.
Right, the decades-long stuff.
Exactly. You smoke for decades, you increase your risk for lung cancer, emphysema, heart disease. But when you dive into the immediate short-term data, you realize smoking isn't just this slow burn toward future illness.
Right.
It's an active, aggressive saboteur of the medical treatments your body needs, like today.
And to figure out how that sabotage actually works, we are unpacking a massive stack of sources for you. We're looking at the UK medical eligibility criteria for contraception, joint briefings from surgical and anesthesia royal colleges.
The heavy hitters.
Yeah, oh, definitely. Plus, deep physiological reviews on how the body synthesizes collagen and clinical guidelines from the National Institute for Health and Care Excellence, or NICE.
And when you pull all these really diverse medical fields together, surgery, gynecology, cellular biology, they all point to the exact same underlying physiological crisis.
Which is what, exactly?
Well, the body is basically being handicapped at the exact moment it needs to perform at its peak.
So let's start by looking at the most dramatic arena where that peak performance is required, right? The operating table.
Yeah, the stakes literally do not get higher.
No, they don't. And when we pulled the data from the joint briefing by the Royal Colleges of Surgeons and Anesthetists, the numbers, they actually made me do a double take.
I'm not surprised.
Just by being a smoker, when you roll into the OR, your risk of dying after the surgery spikes by almost 40%.
38% to be incredibly specific.
Right.
And I mean, that is a staggering leap in mortality for a variable that isn't the underlying disease itself.
It's just a habit you bring into the room.
Right. And on top of that, smokers experience twice the rate of post-surgical complications. And we aren't talking about needing an extra day in the hospital bed to rest.
What kind of complications are we talking about?
These are severe pulmonary and cardiac complications, massive spikes in intensive care admissions, and really critical wound healing failures.
Oh, wow. Does this apply across the board, like, to any surgery? Or are certain procedures more vulnerable?
So the data shows pronounced negative effects across the board, sure, but it is heavily highlighted in orthopedic surgeries.
Like bones and joints?
Yeah, things like hip and knee replacements or foot and ankle fusions where bone desperately needs to knit back together.
Okay, that makes sense.
It's also a major predictive factor for severe complications after colonic and rectal resections, and it drastically increases the risk of tissue death during reconstructive breast surgery.
So I mentioned right at the start that smokers actually require higher doses of anesthetic. Why is that? I mean, I would have assumed a compromised body would need less, not more.
It comes down to a fundamental oxygen crisis. Smokers generally have decreased blood oxygenation.
Because of the smoke itself.
Exactly. Because their blood is physically carrying less oxygen at any given moment, there's a decreased delivery of oxygen to all the tissues in the body, including the brain and vital organs.
Right.
So the anesthesiologist is essentially fighting an uphill battle. They have to work significantly harder to maintain the patient's vitals.
Which means pumping more drugs into the system.
Yep, often requiring higher drug doses just to keep the patient safely under and stable. And then the patient is significantly more likely to need post-operative oxygen therapy just to recover from the sedation.
Man. Okay, let me try to visualize this. Imagine your body undergoing surgery is like a major construction site.
Okay, I like that.
You've got this medical crew trying to rebuild a damaged structure, right? Smoking is essentially like cutting off the supply chain of vital building materials, specifically oxygen and nutrients.
Right, while simultaneously demanding the construction crew work harder, faster, and basically in the dark.
Exactly.
You've hit on the exact reason why surgeons are often incredibly hesitant to operate on active smokers for elective procedures. It's a strictly mathematical clinical risk assessment.
They just look at the odds.
Yeah, they look at that construction site and know the supply lines are compromised before they even make the first incision.
Yeah.
The likelihood of the structure collapsing is just too high.
So if the supply chain is cut off, what exactly is blocking the road?
Yeah.
If we zoom in from the operating room down to the microscopic level of a surgical wound, how does smoke actually dismantle the healing process?
To understand the sabotage, you have to look at the three main stages of wound healing. So you've got inflammation, tissue formation, and remodeling.
Okay.
The physiological reviews show that smoking actively disrupts all three of those stages. And the primary culprit blocking that supply chain you mentioned, it's carbon monoxide.
Carbon monoxide,
Yeah.
which is just a natural byproduct of burning the tobacco, right?
Right. When you inhale combustible cigarette smoke, carbon monoxide, or COO, floods into the bloodstream. And the protein in your red blood cells responsible for carrying oxygen is called hemoglobin.
We've all heard of hemoglobin, yeah.
Well, the critical flaw in human biology here is that carbon monoxide has an affinity for hemoglobin that is roughly 200 times greater than oxygen.
200 times, so it's not even a fair fight.
Not at all. It completely outcompetes oxygen for the seats on the bus, so to speak.
Even if they give you oxygen in the hospital.
Even if you are breathing in pure oxygen, the carbon monoxide refuses to give up its seat. This leads to peripheral tissue hypoxia.
Which means what exactly?
It's a clinical term meaning your tissues are suffocating. A healing wound is an incredibly energy-demanding environment. It desperately needs that oxygen to fuel the cellular repair crew.
Which brings us to how the wound actually closes. The body uses collagen as the scaffolding, right? It's like the main structural protein that knits a wound together and forms a strong scar.
Exactly. And this is where the science gets incredibly elegant, but also kind of devastating. Your body relies on cells called fibroblasts to manufacture that collagen.
Okay, fibroblasts.
When you're exposed to smoke, those fibroblasts decrease their production of type I and 3 collagen. But to understand why the factory shuts down, we have to look at a highly specific family of enzymes called prolo-4-hydroxylases, or P4Hs.
Okay, P4Hs. What is their job on the construction site?
So think of collagen forming in a triple helix structure, very much like a braided rope.
Okay, I'm picturing a braided rope.
For that rope to hold its shape and be stable at normal human body temperature, it requires these P4H enzymes to chemically modify it, specifically by adding a hydroxyl group to an amino acid called proline.
And if that modifying process doesn't happen?
If it doesn't happen, the collagen literally cannot form a functional molecule. It would just disintegrate at normal body heat.
Oh, wow. So the structural integrity of the scar relies entirely on this microscopic enzyme braiding the rope tightly enough.
The problem is that P4H enzymes absolutely require oxygen to function. Oxygen is a mandatory co-substrate. It's the literal tool the enzyme uses to braid the rope.
Oh, I see where this is going.
Yeah. When carbon monoxide starves the tissue of oxygen, those P4H enzymes drop their tools. They're just paralyzed. Collagen synthesis is downgraded, the rope is weak, and you face a much higher risk of wound dehiscence.
Dehiscence, meaning the surgical wound literally breaks open, right?
Yes. The stitches on top might hold, but the tissue underneath just pulls apart because the collagen scaffolding never cured properly.
Okay, let me make sure I'm separating all these elements out, because cigarette smoke is this massive chemical cocktail. Is the slow healing entirely due to the carbon monoxide stealing the oxygen? What about the actual toxic tar or the nicotine itself?
It's a combined assault, actually. Combustible cigarettes are undeniably the worst offender because they deliver all three simultaneously: the carbon monoxide, the tar, and the nicotine.
Right, the triple threat.
We know the CO suffocates the tissue. The tar, on the other hand, introduces a massive mixture of carcinogens and toxins that stimulate pro-inflammatory cytokines.
Cytokines. Can you translate that for us?
Sure. Cytokines are essentially the chemical alarm bells of the immune system. When the tar hits your system, it triggers these alarms to ring constantly and loudly.
So your body thinks it's under attack everywhere.
Exactly. Your immune system goes into a state of chronic misdirected inflammation. Instead of quietly focusing its energy on repairing the surgical wound, the body is distracted, just fighting this systemic toxic fire.
And the nicotine. We haven't really touched on what the addictive chemical itself is doing to the wound.
Nicotine is a potent vasoconstrictor. That means it physically shrinks the diameter of your blood vessels, clamping down on blood flow to the skin and peripheral tissues.
Okay, so not only is the blood lacking oxygen because of the CO,
Right.
but the nicotine ensures less of that blood is even reaching the wound in the first place.
You've got it. Plus, nicotine inhibits the migration of keratinocytes.
Keratinocytes. Those are the cells that essentially resurface the wound, right? They build a new top layer of skin.
Yeah, that process is called re-epithelialization. Nicotine stops those specific surface cells from effectively migrating across the wound bed to close the gap.
Okay, wait, hold on. This naturally brings up a massive question for anyone listening who has switched to e-cigarettes.
Ah, vaping,
Right.
yeah.
Vaping has no tar, there's no combustion, which means there is virtually no carbon monoxide. The oxygen is flowing fine, the smoke toxins are gone. How can vaping possibly still be a major surgical risk?
It seems counterintuitive, doesn't it? But the sources we reviewed, specifically a really comprehensive review from the European Society of Medicine, make it very clear. Vaping cannot yet be considered a safe alternative for surgical patients.
Because it still delivers massive amounts of nicotine, so you still get the shrinking blood
You
vessels.
get the severe vasoconstriction, yes. But the cellular biology reveals something even deeper. The evidence shows that heavy nicotine exposure via e-cigarettes induces mitochondrial stress in those fibroblast cells we talked about earlier.
The ones building the collagen scaffolding.
Exactly.
Mitochondrial stress, meaning it attacks the powerhouses of the cell.
You can think of mitochondria as the microscopic batteries powering the cellular repair crew. Nicotine essentially drains those batteries. The cells go into a state of oxidative stress.
Wow.
So even without the tar and the carbon monoxide, you're actively cutting the power to the very cells trying to build your scar tissue.
That is a brutal mechanism to understand. But this begs another question. If nicotine is shutting down the cell batteries and shrinking blood vessels, what does this mean for nicotine replacement therapy?
Like patches and gum.
Yeah, exactly. Doctors actively prescribe those to help people quit before surgery.
This is a vital nuance in clinical care, actually, and it's where harm reduction comes into play. Nicotine replacement therapy, or NRT, is definitely safer than smoking in a perioperative setting.
Okay, good to know.
High, continuous doses of nicotine from a patch can still cause vasoconstriction and delay healing to some degree. However, clinical consensus agrees that it is a highly recommended transitional strategy.
Because it's the lesser of two evils.
Yeah.
Like you're trading the three-pronged attack for a one-pronged attack.
Precisely that. By using a patch, you completely eliminate the carbon monoxide and the tar. You remove the most aggressive, immediate barriers to oxygen delivery. The physiological reviews note that removing that CO allows tissue oxygenation to restore incredibly fast. So right around the time of surgery, switching a patient from combustible cigarettes to NRT is a massive win for their healing outcomes.
Okay, so if smoking is this destructive to acute traumatic wounds, like a surgical incision, what is it doing to the body during everyday routine medical care? Like, is it sabotaging things we don't even consider procedures? Let's look at contraception.
This is an area where smoking has profound, immediate implications on daily medical care that, honestly, many people are completely unaware of. We pulled the UK medical eligibility criteria for contraceptive use, known as the UK MX.
Right.
This is the gold standard guideline doctors use to prescribe contraception safely. It categorizes risk levels from 1 to 4. Category 1 means there's no restriction. Category 4 means the condition represents an unacceptable health risk.
The absolute highest warning level they have, where does smoking fall on that scale?
According to the UKMX summary table, prescribing combined hormonal contraception, that's the combined pill, the contraceptive patch, or the vaginal ring, is classified as a Category 4 condition for women aged 35 or older who smoke 15 or more cigarettes a day.
An unacceptable health risk just for taking a daily pill. Why is it so incredibly dangerous for that specific demographic?
Because of how the chemicals interact in the vascular system, the estrogen in combined contraceptives naturally increases the blood's tendency to clot slightly.
Okay.
When you combine that estrogen with advancing age and the severe vascular damage and vasoconstriction caused by heavy smoking, you create a perfect storm.
It just compounds the issue.
Exactly. It leads to a highly elevated risk of severe cardiovascular events, venous thromboembolism, which are dangerous deep vein blood clots, myocardial infarction, which is a heart attack, and stroke.
Let me give you an analogy to see if I'm tracking the mechanics of this. Prescribing the combined pill to a heavy smoker is kind of like trying to pump wet cement through a shrinking garden hose.
Ooh, that's a good one.
Like, the estrogen is making the fluid thicker and stickier, while the nicotine is simultaneously narrowing the pathway. A catastrophic blockage isn't just a possibility, it's almost inevitable.
That perfectly illustrates the compounding vascular stress. A doctor looking at that chart simply will not prescribe the combined pill to a 36-year-old who smokes a pack a day because the treatment itself becomes a life-threatening hazard.
Man. Another chronic condition mentioned in the sources that really surprised me was pelvic organ prolapse.
Oh, yeah.
It's not a chemical interaction, but how does smoking interfere with healing a prolapse?
Well, pelvic organ prolapse occurs when the muscles and tissues supporting the pelvic organs weaken, causing them to drop out of their normal position. Treatment often involves intensive physical therapy to strengthen the pelvic floor, or sometimes surgical mesh repairs.
Okay, so it's a structural fix.
Exactly. But smoking introduces a major physical barrier to healing: the chronic smoker's cough.
Oh, of course. Coughing creates intense downward pressure in the body.
It creates repetitive, violent intra-abdominal pressure. Every single time the patient coughs, they are actively bearing down on and straining the exact pelvic floor muscles that the medical treatments are trying to repair.
So treating a pelvic organ prolapse while smoking is like trying to fix a leaky pipe under your sink while someone else keeps violently kicking the pipes from the outside.
Pretty much.
You're never going to get the seal to hold. It's a purely mechanical sabotage.
The mechanical stress completely undermines symptom recovery. Whether it is chemical, vascular, or mechanical, smoking doesn't just sit passively in the background. It actively fights the interventions we use to try and heal the body.
Well, with all this rather bleak biological reality we've been discussing, I have to ask the ultimate learner's question. Is this reversible? Like, if you have a surgery scheduled and you stop smoking, does the construction site get its supplies back in time?
The data actually provides a tremendous amount of hope here. The medical community views a hospital admission or the planning of a surgery as a vital, teachable moment.
A teachable moment.
Yeah. Patients are facing a major health event and are highly receptive to intervention. Plus, hospitals are strict no-smoking environments, which forces a break in the physical routine anyway.
So, what is the timeline? If I have a knee replacement scheduled, when do I need to stop to actually see a statistical benefit in how I heal?
The clinical consensus shows that quitting 4 to 8 weeks before surgery provides the greatest benefit.
4 to 8 weeks. That's a relatively short window to undo what might be decades of smoking.
The human body is remarkably resilient when you stop poisoning it. The data shows that quitting in that 4 to 8 week window is associated with a massive 41% reduction in postoperative complications.
A 41% reduction. That is a staggering improvement in your chances for treatment success.
It's profound, but it is important to manage expectations about what recovers quickly and what takes time.
Right, because it's not magic.
No. As we discussed, once you remove the carbon monoxide, your hemoglobin is freed up. Tissue oxygenation restores very rapidly, almost immediately. And that inflammatory response, those cytokine alarm bells constantly ringing, partially reverses within about 4 weeks.
But what about the collagen scaffolding? Did the cell batteries recharge that fast?
The proliferative response, which includes that complex collagen building by the fibroblasts, remains impaired for much longer. The structural integrity takes time to return to a baseline normal.
Okay, but at least the oxygen is back.
Exactly. Getting the oxygen back online immediately stops the worst of the acute risks.
What if someone can't quit a month out? What if they only stop, like, a few days before?
The guidelines are unequivocal on this. Even temporary abstinence immediately around the time of surgery helps. Every single day without carbon monoxide and vascular constriction improves the tissue's chance of surviving and knitting back together.
So how do healthcare professionals capitalize on this teachable moment? What's the clinical strategy when a smoker walks into a pre-op appointment?
The standard of care recommended by NICE guidelines is an intervention called Very Brief Advice, or VBA.
Okay, VBA, what does that entail?
It consists of 3 simple, rapid steps for the clinician: ask, advise, act. First, ask and record their smoking status. Second, advise the patient on the personal health benefits of stopping, specifically relating to the surgery they're about to undergo.
Making it relevant to today, not 20 years from now.
Exactly.
And the third step, act.
Act on their response. This means immediately prescribing stop smoking medication, monitoring their withdrawal symptoms, or referring them to a specialized stop smoking service.
But realistically, addiction is incredibly powerful. What if the patient just flat out refuses to quit, even facing a 41% complication risk?
That is where harm reduction is formally integrated into care. NICE guidelines explicitly support harm reduction strategies.
So they don't just give up on the patient.
Never. If a patient won't quit, clinicians are advised to help them cut down the number of cigarettes, delay their first cigarette of the day, or temporarily switch to nicotine replacement therapy like a patch while in the hospital. Any reduction in toxic smoke inhalation directly improves clinical outcomes.
Hearing all of this, it sounds like this isn't just about pushing a healthy lifestyle on individuals. This is about saving the healthcare system itself from collapsing under avoidable complications.
Oh, the economics of it are undeniable. Quitting isn't just a lifestyle choice. It is a highly cost-effective medical intervention.
Because complications are expensive.
Very. By reducing post-operative complications by 41%, you're directly saving the healthcare system massive amounts of money and resources. You're drastically reducing the days patients spend occupying hospital beds, preventing emergency readmissions for infected wounds, and lowering the demand for intensive care units.
Let's bring this all together. We started with a mission to find out how smoking sabotages medical treatments in the short term. And, I mean, the evidence is overwhelming.
It really is.
Smoking doesn't just cause future diseases. It actively fights against today's medical treatments. From the higher dose of anesthesia you require just to survive surgery, to the oxygen-starved collagen your body desperately needs to close a wound, to the immediate vascular dangers of your daily contraception.
Right.
The smoke, the carbon monoxide, and the nicotine are actively dismantling the very treatments meant to heal you.
And if we step back and look at just how finely tuned our bodies are, it leaves us with a profound realization about the invisible damage happening every single day.
Yeah.
Think back to those P4H enzymes we discussed, the microscopic workers that braid your collagen together. They are incredibly rapid oxygen-sensing mechanisms. The very second they're deprived of oxygen by carbon monoxide, they immediately drop their tools and downgrade tissue repair.
They don't wait for cancer to develop. They just shut down the assembly line today.
Exactly. So it raises a lingering question. If our cells possess such profound, rapid oxygen-sensing mechanisms that immediately pause wound healing, what other subtle microscopic repair processes in our bodies are being silently paused every single day by even occasional exposure to carbon monoxide and nicotine?
Wow. That is a wild thought to mull over.
Yeah.
The invisible pauses in our body's daily maintenance. Well, thank you for joining us on this deep dive. Keep asking questions, keep looking past the surface, and keep connecting the dots.